Thank you. Obviously, I'm going to talk about the subject from a different angle. Hopefully, I'll also be able to give you a few ideas as to where we're going in terms of the bladder, which is in a way easier to understand, but probably tells us about other parts of the body as well. I thought I'd start with a case. It is a probably quite a difficult case, but brings in all sorts of different issues. And so this was a 50-year-old who in 2008 suddenly developed urinary symptoms, and it was severe pain on passing urine 12 times during the day. She was actually also getting up 3 times at night. And when the doctors tested the urine, they saw lots of white cells and they saw blood, which should mean an infection. And they didn't really send the urine off for a testing, but then gave her trimethoprim, and nothing really happened. They then retested the urine. It was negative, but the symptoms were the same. And when they sent the urine off, it said no significant growth. And one of the problems is that, unfortunately, when the original definitions were given for urine and cultures, the person in 1955 actually said, in his paper specifically, if you have symptoms, you can't use my cutoff. And unfortunately, the cutoffs are still being used. So that no significant doesn't actually mean anything at all. It means they did find something, but they decided to ignore it. So the symptoms worsened, and the patient just was fluctuating, feeling unwell. She was seen in 2015, so 7 years later, a very severe nocturia. She was waking up 6 or 7 times at night, continued to pass urine 12 times during the day, and her symptoms would fluctuate. She'd have lots of sweats and chills. All the blood tests showed no abnormal markers for infection. CRP a little bit elevated, maybe at 5 or 6, but not something which would be considered significant. Lots of muscle and joint pains. ESR, CRP, all the rheumatological antibody tests were negative. And then she started to get problems with dysphagia, not being able to eat properly, and gastritis, but which was not too severe, was noted on endoscopy. She also complained of pelvic pain and lower back pain. I'm sorry, I'm going to give you a whole load of symptoms. And she also had postnasal drip, sinusitis, problems with breathing, but when they did the peak flow tests, it was all normal. Oxygen was always normal, but she just couldn't catch a breath. And she'd get intermittent chest pain and pressure. It was more pressure on the chest, but all the cardiac investigations were normal. She'd get palpitations, irregular heartbeat, migraines which weren't responsive to treatment, pain in the right upper quadrant of the abdomen, no gallstones were found, but her liver function tests kept changing, and nobody could quite work out what was going on. And then you got loads more, nausea, vomiting, lots of bowel symptoms, low white cells, lymphocytes, low ferritin, itching, edema, and dermographism. And we go on. Now, eventually, in terms of blood tests, she was finally diagnosed, I think it was Professor Graham saw her, and diagnosed her as having joint hypermobility. And in fact, the whole family has joint hypermobility. And they had very prolonged dermatography, and they missed this enzyme called diamine oxidase. It's 7.8, so they have, this woman has histamine intolerance. She also has virtually absent mannose binding lectin, and it's this very special protein which is needed by white blood cells to grab bacteria. So there are probably around about, if you do on PubMed, you'll see about 1,000 papers about mannose binding lectin, and people are more predisposed towards not being able to get rid of infection effectively. She has low immunoglobulins, IG1, IG3, so testing for immunoglobulins wasn't going to really find anything. And testing her urine, she did have a mixed growth, which turned out to be an enterococcus and strep. She's then started on loratadine, so antihistamines, and ranitidine, a histamine type 2 receptor blocker. She started on a low histamine diet. She was then treated on nitrofurantoin for 2 weeks, and the nighttime frequency did get better. And after a month, she still had frequency dysuria. And the fatigue was gradually improving. But, obviously, this is a subclass of patient. Not everyone is the same. There are many, many different aspects to joint hypermobility. So just like we might look at joint hypermobility and we see that it affects many, many different systems, when we look at the immune system or we look at infection, there are many different types. We thought originally there were just going to be two, and I'll talk about the main two from the tests we've done, but my suspicion is we're probably going to see lots and lots of different tests, different groups, different tests, because we see different responses of people to treatment. And it is very much about investigating what's the underlying disorder for that particular person. So talking specifically about urinary tract symptoms and joint hypermobility. First, looking at children, this study from 2003 looked at 89 joint hypermobile patients compared to 116 controls, and they were diagnosed on the Byton and Bulbena scales. And girls had more day and nighttime incontinence, so that was 38% compared with 14% of the controls. And in terms of nighttime incontinence, 13% compared with 2%, which is, it's very high. And interestingly, urinary tract infections, 24% had urinary tract infections in the joint hypermobile group compared with controls. So we see this it's not just, this was something where they selected a group of patients with joint hypermobility and then looked backwards. So it does seem to have a high prevalence. There are this is very small print, but there are lots of different genes in terms of hypermobility, and this creates problems because not all hypermobility may have the same impact in terms of the immune system. So it really does need defining. What about in women? Out of 175 women with lower tract dysfunction, again, a non-selected group who were seen in hospital because of their bladder problems, using a 5-point questionnaire, 26% had hypermobile EDS. And what was interesting is we've always thought that if somebody has hypermobility, that because it's supposed to be stretchy collagen, the person must have stress incontinence. And surprisingly, it was actually having an overactive bladder, so having frequency, urgency, which was actually the predominant problem, not having stress incontinence. And they actually less likely to have stress incontinence and mixed. So a really surprise. Now, the reason why that's so important is we now know that detrusor overactivity is actually associated with infection. So there appears to be certainly at least 50% of patients with an overactive bladder who actually have infection. The other important thing is that patients with detrusor overactivity, 50% of them have irritable bowel. So that's also associated with EDS. So it's quite interesting. What about looking at a smaller group where they looked in great detail to diagnose the hypermobility? Because the other one was a questionnaire, and questionnaires can always be not quite as good. Even though they're easy to administer, the data may not be as good. And in this study by Mestrudes, she looked at 30 women with joint hypermobility who were clinically diagnosed in a hypermobility clinic, and then they had 30 controls. And then they looked at the urinary symptoms, and they found that there was double the rate of incontinence. 60% had urinary incontinence compared with 30% of the controls, and 23% had fecal incontinence. So, a lot of problems which may not necessarily be picked up because it's considered to be just a muscle joint problem. What about members of the HMSA? Well, this was a survey, a questionnaire survey of 373 members who all had confirmed hospital diagnoses, and there was a 39% response rate. And looking in terms of urinary incontinence, it was around 68% in the members of the society compared with 30% in controls. And fecal incontinence, again, much higher, 15% compared with 2% in controls. And they also found that BMI was associated with fecal incontinence, which is actually in the general population. We find that bladder and bowel problems are associated with BMI. What about POTS? Much more select group, a group of people where if they stand up, their heart rate increases because their body's trying to maintain blood pressure. It's a form of autonomic dysfunction. And this was looking at 22 women with POTS and EDS, and 20 of them were found to have detrusor activity on urodynamics. Now, what's important is these women were specifically referred because of bladder problems. So we were expecting to find something, but what we weren't expecting was to find virtually all of them had an overactive bladder. And also 14 women had painful bladders as well. So pain, overactivity seems to be on the same sort of spectrum. So what about EDS hypermobility and LUTS? Well, it's much more common in women, 4-to-1, and obviously we find in general that it divides into 3 groups, the urinary symptoms. Obviously, what I've been focusing on is frequency, urgency, bladder pain, but we find infrequent voiders, so people who maybe pass urine 2-3 times a day, and they have the potential for, if they have for an operation or they're given certain drugs, that they could go into retention, so they can't pass urine. There's another group who get frequency and urgency, and then there's another group who get painful bladder. So I've spoken a lot about urinary symptoms, but are there any other odd features? And this is what has become very strange from our perspective, looking at bladders, is that we start to see, and you can see the picture on the left, and you know, this lady had lots and lots of rashes, had become very fatigued, and that was her once she'd had treatment. But she actually had a low-grade infection which needed to be treated over about 3 months, and also the inflammatory side had to settle before she felt better. When we look inside the bladder, we'll see, sometimes we'll quite often see bleeding and evidence of inflammation. So as the bladder fills, it starts to bleed. And that's why when urine's tested, quite often one will notice blood. So what's going on here? We've got these symptoms. We've got these findings, such as bleeding. What could be behind it? And what about when we're measuring urine tests that we find this no significant growth or not finding the infection in the first place? And the answer really comes from, this is mainly work which has been done on detrusor overactivity. So we would expect at least 70% of these patients to have had joint hypermobility. Now, we're now starting to do this study in hypermobile patients to actually really prove it. But basically, this is a study back from 2000, actually. And what they did was they got E. coli, put it into mouse bladders, and when the infection is left for 10 days, something strange happens. The body responds to the bacteria. It wants to get rid of them. So the only way it can do it is it jettisons the surface cells of the bladder. Now, the surface cells of the bladder are very good at keeping bugs at bay. But the problem is, once that surface layer is shed, the bacteria then penetrate, and then what they found was that you get biopods in the bladder. And there was an excellent paper back from 1990 where somebody looked at women who were getting repeated infections, and they just couldn't find, even though they were treating them every month, they found exactly the same bacteria would come back again and again. And basically, they're living in little pods. And when we look further, in the top picture, you can see a bladder wall in a human, and that purple thing, when we cut it up, you can see it's a group of bacteria living in a pod. So, okay, there are abnormal bacteria, but what do bacteria do in general? Now, we've always thought that a normal bladder has no bacteria. And actually what's turning out now with DNA studies is that in the bladder there are lactobacilli, there are streps and there are staph, and it's actually a real environment. There are loads and loads of bacteria living there. So there are actually good bacteria and bad bacteria. And the problem is that in a way we're trying to kill off the bad ones, but then you sort of clear the way and it's whoever turns up again the next time as to whether or not the infection occurs again. And when we look at the bladder, you can see that bacteria can actually, they apparently have been found to destroy toxins in the urine. Good bacteria will stop bad bacteria from invading the bladder. So, for example, there's a Swedish group who've treated children who've had recurrent infections by putting good bacteria in the bladder. They put good E. coli in and they displace everything and the infection stops. They also can obviously invade and they can cause other problems. So bacteria can be good and bad. So what we then did was look at people with urgency and urinary incontinence and try and see which bacteria seem to be significant. And this is really the first set of data. It's from what I remember, about 160 people. And what we found by looking at bladder biopsies, that there are certain bacteria which are associated with urinary symptoms. So there are protective bacteria and there are dangerous bacteria. So, well, not dangerous, but you know, the key thing is that there are bacteria which cause problems. And then this was one which specifically was associated with urinary incontinence, which is the Neurococcus, which, you know, I'll be honest with you, in 30 years I've never grown it. Maybe it's because what we're doing is we're putting media out because we're looking for a certain bug. We're looking for E. coli, we're looking for Enterococcus. We're not looking for this bacteria, so we never grow it. And what's important is we find the bacteria which are in the vagina and the bladder are very similar. So it's quite key. If there are bad bacteria in the vagina, they'll get into the bladder. So what's all this about? What's actually happening? And when we look at, I'll just quickly go through about the immune system. What happens, these are studies, I'm afraid this is on mice, but basically mice can divide into 3 groups if they get an infection. There's one group who will just get rid of the infection spontaneously. So they're the people who, when they get an infection, they drink loads of water, flush it out, it's gone. And what they have, bizarrely, is a weak to moderate host response. The immune system's doesn't get that angry at all. Then there's another group who actually don't have much of an immune response at all. And we see this as elderly patients who have very infected pea soup urine, but they have no symptoms. And then there's the last group who have a very, very angry immune response. And that's probably where we're thinking the EDS patients are, that their body gets really annoyed. And unfortunately, being too annoyed is not helpful because it causes all the other symptoms. So the immune system, there are lots and lots of different parts to it. And the key bit is the innate immune system, which is your barrier in terms of the skin, and then the actual cells which will turn up at a first infection. They're the ones which cause the redness, irritation, inflammation. And then there's the adaptive immune system, which is the antibodies. And really, up till now, that's where all the focus has always been. And unfortunately, that's not what is involved in this problem. I'll just go on to what the innate immune system is. It basically involves mast cells, and mast cells respond by releasing lots of chemicals which cause inflammation and pain. So it's when you get a cut, that's what causes the cut to go red and be very painful. There's also the mannose binding lectin, which is this protein which is found on white blood cells and actually on cells in the body. And it's very important because it releases very toxic chemicals which will kill bacteria and kill viruses. Very non-specific. It's almost like, exploding a bomb, basically. But the key thing is, it then helps keep bacteria under control. And this is a picture of a white blood cell. That thing, the grey thing in the left side, is almost like an arm coming off the white blood cell, and they need this lectin protein to attach to bacteria. And what they do is they actually scoop the bacteria up and eat them. But if you don't have that protein, you don't have that stickiness. So what have we found? We found certainly higher rates of painful bladder, urgency and frequency in patients with joint hypermobility. 40% have reduced diamine oxidase, which is an enzyme for destroying histamine. So basically, it means everything's really geared up for a fight. 35% have reduced levels. Now, in the general population, reduced diamine oxidase activity, 2%, not 40%. And if we look at the general population, mannose binding lectin being reduced, it's around 5%. And we've certainly found other groups of patients who have lots and lots of mast cells in the bladder. And if you have lots of mast cells, you'll produce lots of histamine. Okay, well, you may say, oh, well, that sounds all fancy and fine, but is there any real evidence? And there's an excellent paper which came out November last year in Nature Genetics, which looked at 25 families with EDS hypermobility. And they had independent teams looking at fatigue, fibromyalgia, irritable bowel, skin rashes. They didn't really look at urinary, sadly. But they then looked at the genes, and they specifically looked at something called an alpha tryptase gene. And what they found was that the alpha tryptase gene, in those people who are more affected, because these are whole families, so there are people who aren't affected, people who are affected in the family. And they found that the number of copies of the alpha tryptase gene defined how affected the person was, which then explains why not everyone has the same symptoms in a family. Okay, so conclusion. There are higher rates of overactive bladder and also painful bladder in women with EDS hypermobility type. We certainly see in certain organisms in the bladder and the urine, and they're often at very low levels. And there's something odd going on in terms of the immune system, that there's an abnormality of the enzymes, and there's also an abnormality of this thing called mannose binding lectin. But as I said, I think there'll be lots more. This is just one small part of it. And I'm sure, ultimately, this is an evolutionary adaptation. All changes are always for a purpose. And it probably means that infections can be contained. The only problem is the consequences are symptoms. But evolution is not interested in symptoms, it's only interested in survival. Thank you very much.